So glad to see everyone.
Good to be here too.
Yes, glad to have everyone here. Dr. Tennant, we have some really good news, and I didn't know if you'd want us to share this first or afterwards.
Well, if we have good news, go ahead and share it.
We really do. Alan, would you like to share, or would you like for me to share?
I can go ahead and share.
Please do.
I had tried, I picked up some of the PEA supplement with, I'm not sure if this one had the luteolin in it, but I was taking that and the BPC 157 in addition to colostrum and the taurine. That change, the BPC 157 and the PEA, I would equate it to taking a hydrocodone as far as the relief went. So I'm 2 weeks into it now, so I'm excited.
Well, thank you very much. Incidentally, that doesn't surprise me. We are getting a lot of different reports, and maybe the next session we should talk about the combinations of PEA with a lot of the different things. But what you're talking to me about ought to be almost, you're right on schedule for the future, which gets a good chance for me to get started here in a minute. Also, I see we've got some good news on here. My good associate, Dr. Ibsen's here. He's got some really good news to tell us about too later. Okay, but your BPC and PEA is a winner when they're used together, okay? Because you're getting both a hormone and a peptide together, okay? Remember, PEA is a hormone, okay? The combination of hormones and peptides is really kind of a wave of the future. In fact, I'm going to digress for just a moment based on what you've just said. If you take a look at probably not only adhesive arachnoiditis, but CRPS or any of the other severe pain syndromes, you can divide long-term treatment really into two segments. The first segment has to be inflammation suppression. But then you get in, once you calm the inflammation down, you want to move into the neuroregeneration phase. And that's where your PEA and your BPC, your DHEA, colostrum, those things come in. In other words, you're going to hear me talking a lot about phase one, that's suppression of inflammation and autoimmunity. But once you get that calmed down, you want to move right into neuroregeneration. Okay, those two phases. So that's really where it's at. And you're headlining it here. Thank you so much. You made my day, as a matter of fact. Matter of fact, I might just cancel my show and focus on what you just said. It's probably more important. Okay. Anyway, I'm going to give a little presentation, and I see Dr. Ibsen's here. He has some awfully good news to tell us about also. Anyway, I almost would rather stick with PEA and BPC for the moment because I'm going to talk about one of my most unfavorite subjects tonight. And the reason it's unfavorable, nobody believes me and nobody cares about the subject I'm going to talk about, and that's the subject of intervertebral discs, okay? Nobody wants to hear what I'm going to talk about tonight, or they want to ignore it, but nevertheless, it's something everybody needs to hear. First off, what is the intervertebral discs? Well, everybody knows you've got a spine, and when people think of the spine, they really think of what's called a vertebra. That's the big, heavy bones that are the backbone, if you will, of the spine. But in between each of these is something called an intervertebral disc. Most people refer to them as a disc. Most people don't know what they really are. They're really a soft cushion made of collagen, and they're very soft and flexible, so you can bend over, you can reach, you can walk. If we didn't have discs, you couldn't move. So discs are critical for movement, and they're very poorly understood, and everybody has a bias about what discs mean. But to get my presentation started, I want to tell you about a report that I came across here 3 or 4 years ago. Some years ago, there were some of the early people back in Dr. Aldretti's days that were studying adhesive arachnoiditis, and they wrote a paper saying, does arachnoiditis only occur after discs are degenerated? And that was a question, And it turns out the answer is probably yes. Now, after seeing that report in that paper, I started to do my own studies. Now, at Arachnoiditis Hope, literally, we've probably reviewed now somewhere between 1,500 and 2,000 cases of documented adhesive arachnoiditis and other spine problems. And this might sound amazing to you. I could count on one hand the number of people with adhesive arachnoiditis who do not have degenerated intervertebral discs. In other words, it's almost 100%. And you almost, after a while, you almost start thinking, can you even get adhesive arachnoiditis without degenerated discs? Okay. Now, the reason why nobody likes to hear what I'm about to talk about is nobody wants to talk about where those discs came from or what you do about them or how important they are. But I'm going to tell you what we've learned because we think it's a critical issue here that everybody who has these diseases should know about. Okay. Now, first off, I want to kind of show you what we've learned on how these discs cause adhesive arachnoiditis. Okay, there's two mechanisms, and I'm going to sort of diagram them for you and give you a little idea on how it works. I hope you can see this piece of paper. Now, on this piece of paper, you should have 3 blocks here that have V's on them. These are for vertebra. Now, in between each of these, you've got discs. Now, everybody is familiar with the term slip discs or herniated disc. And incidentally, I'm not a fan of those terms particularly, but what they mean is that you have these here and that the disc has slipped or moved or herniated inward toward the spinal column from its natural layout, okay? So that's what that means. Slipped, it slipped out of its natural space. Now, what people don't understand and what we've now come to realize is so critical is where it slips to. Nobody's talked about that except we have to now understand it thoroughly. Now, the first thing it does, when it slips into an anatomical site called the epidural space. That's the same place they give the injections, okay? So there is a space between there and the arachnoid or the spinal canal cover, okay? The spinal canal cover. So if you slip, it slips and then it presses upon the spinal canal cover. Now the cover is comprised of 2 layers, at least in the lower spine, the dura and the arachnoid. Okay. Now, here is what happens. When those discs degenerate, and incidentally, they only slip after they've fallen apart. As long as they're solid, they stay in place. But when they degenerate or crumble, the word degeneration also means crumble. When the disc starts to crumble, it starts to come out. And it crumbles and it presses against goes through the epidural space and presses upon the dura and the arachnoid. Okay? That's what it does. Okay. Now, so you say, so what? Here is the so what. We've now learned 2 things about these discs. One is it's a mass. And if you take that mass and you put that mass into the epidural space, pressing upon the dura and the arachnoid, you actually bend the arachnoid. You bend it. And what happens if you bend anything too long? It cracks. We call it fissuring. Okay? So that herniated disc, that slip disc, that degenerated disc comes out of its natural slot, presses against the final canal cover, which includes the arachnoid. If you put pressure on the arachnoid is a very thin group of collagen-filled cells. It cracks them. All you have to do is put one little crack in an epidural cell, in an arachnoid cell, and then you allow spinal fluid to come in, contaminants to come in, and it becomes inflamed. So all of a sudden you have inflammation in the arachnoid membrane. Now the second thing is, and here's the one that nobody wants to hear about. Why did the disc degenerate? Okay, now I want to do this. I must have asked, if I've asked 10, I've asked 100 patients who had disc surgery. I've asked all of them, what did your doctors, why did they tell you your disc degenerated? And what do you think they tell me? Nobody ever told them why. All they know is they went to surgery, they're now incapacitated. They had these degenerated discs, and nobody told them why. At best, they'll say it was normal wear and tear. Now, granted, we have people who get injured. Injuries, picking up heavy boxes, falling, you can slip your disc or herniate your disc, obviously, with severe trauma. But when you're told it's normal wear and tear, guess what? I don't buy it. The discs are there and made to stay intact until you're 100 years of age. They are not made, they do not have normal wear and tear. There is no such thing with a disc. Now you know why no one wants to hear this lecture. The whole medical field right now wants to excuse all these discs that are degenerating and protruding and slipping on normal wear and tear. Normal wear and tear doesn't exist, okay? No more so than your knee or your elbow. It's, in other words, those discs are made to hold up until between your birth and your death. There is some other reason why they have degenerated. Now here is what nobody wants to really get into, but I'm going to have to get into it with you. It's only been a few months ago that some studies revealed that these discs that are degenerating and herniating are inflamed, okay? They are inflamed. And they're degenerating because there's inflammation in those discs, just like the inflammation around a cut or a pimple, okay? So the discs are inflamed and they're crumbling. The question is, where'd the inflammation come from? What caused the inflammation in the disc? That's my question for everybody here tonight. You tell me, where did the degeneration in the disc come from? Now I'm going to tell you what our studies tell us, which no one wants to hear, okay? Here is what we are finding out in people with arachnoiditis who have these crumbling discs. What we have found out is all these people either have an autoimmune disease or they have an infection. And the infections usually are either Lyme disease or a reactivated Epstein-Barr. We're also seeing a lot of people with these discs that have 3 and 4 different viruses that look like might have reactivated: herpes 6, cytomegalovirus, paraparavirus. In other words, what we are starting to believe here is that infections are entering, or autoimmunity is entering the disc and causing them to crumble and setting up this chain reaction. In other words, we've now tested, I don't know how many people who have multiple discs that have crumbled in both their neck and in their lumbar spine, and every one we test have some kind of autoimmunity, either from a disease like lupus or psoriasis or Sjogren's or one of those diseases, or they have one of the viruses, usually Epstein-Barr. Those people who have a genetic connective tissue disorder are very susceptible to crumbling of discs. Why? Because the discs are made of collagen. Connective tissue diseases are really a defect in collagen. So people with EDS, people with Marfan's, people with one of these genetic connective tissue diseases are very prone to having crumbling, degenerating discs and going on to develop adhesive arachnoiditis and pain, okay? So where do we stand with all this? Well, this is where I'm not just certain what to say. I do know this. I can say unequivocally, if a person has multiple degenerated discs, they are at risk, if you will, to develop adhesive arachnoiditis. They are at great risk if they take an epidural injection. That puts them at a greater risk. But what's the treatment today in modern medicine for degenerated discs? Epidural corticosteroid injections. All right. Now you know why we have such a high correlation between epidural injections and adhesive arachnoiditis. The corticoid epidural injections on top of a degenerating disc. Now, I haven't really mentioned it, but I've got to also say this. If that disc is inflamed and degenerating, and it's pressing upon the dura and the arachnoid, it can spread inflammation right into the dura and into the arachnoid. In other words, the degenerating disc can either cause a crack or fissure in the arachnoid membrane, or it can pass inflammation right through the dura onto the arachnoid. Now, again, some of you have heard me talk about this. You don't just get adhesive arachnoiditis. Almost everybody first has what we call acute plain arachnoiditis or non-adhesive arachnoiditis. That means inflammation of the arachnoid membrane. If you don't resolve that, it goes on and becomes chronic adhesive arachnoiditis. Chronic arachnoiditis, after a while, will pass inflammation onto the cauda equina because the cauda equina rests on the sides of the canal, particularly when you're sleeping. But it kind of captures the cauda equina nerve roots, inflames them, then adhesions form, and you get a gluing of the cauda equina with the arachnoid membrane. In other words, you start off with something that causes the disc to degenerate or crumble. It slips or protrudes, presses upon the canal cover and the arachnoid membrane, and either passes inflammation or cracks it to where inflammation will start on its own. Bottom line is, you've just set up the scenario to develop adhesive arachnoiditis at some time in the future. So that's what we know about the discs. Now, obviously, one of the questions is, what do you do if you know you have discs that have slipped or discs that are degenerated? What do you do about it? Well, I'm going to be honest about it. I can give you what I recommend. I don't know how successful it is. Maybe there's something better to do, but I can give you my own views on what I recommend. The first thing you want to know is that disc is degenerating because of inflammation. There's nothing wrong with taking, turmeric, luteolin, serrapeptase. There's a lot of the good herbal anti-inflammatories. I suggest you take a couple of them because remember, if that disc is inflamed, it's as subject to trying to have it suppressed as anything else. So I like the idea of taking some herbal anti-inflammatories. Exercise. What I like about exercise for discs is stretching. When you stretch up like this, straight up, you stretch your spine up. That loosens up the space in between the vertebra and maybe gets a little extra blood supply into that disc. So I like plain old stretching exercises for discs, okay, to try to get the blood supply flowing in there a little better. Give it some air, give it some blood by stretching upward. So stretching your hands up several times a day, walking vigorously with your arms swinging, these things all help the discs. So I do recommend those. There, Jamie's doing it right there. You give him a demonstration. There you go. You can't go wrong with this, okay? It keeps the blood flow to the disc. I highly recommend it.
Yeah.
Of course, most of you know I like trampolines. I like walking on treadmills. I like to stay active with those arms and legs for the discs. Now, lastly, you just heard a nice rendition of BPC 157 with PEA, and that's what I call the anabolic program. What do I mean by anabolic? Anabolic means growth. Catabolic means deterioration. Anabolic means you're going to grow. That's why the term anabolic steroids means you're going to grow with that with that steroid, but you need what I call an anabolic program. And I think if you've got multiple discs that you happen to know are slipped or degenerating, things like you just heard tonight, the peptides, some of the hormones, collagen supplements, amino acid supplements, you can't go wrong with those things. So these programs that try to build tissue are very applicable to those discs. Remember, the disc is just another tissue that will grow if you feed it proteins and collagen. And then if you want to boost it with some peptides and hormones, you're just ahead of the game. So that's where we are at on it. Let me summarize it. Our studies, well, no, one last thing that I've got to talk about, and the one that's most controversial. We continue to find in our testing that the Epstein-Barr virus does reactivate, it does cause autoimmunity, and is responsible for an awful lot more medical painful conditions than is appreciated. And in our testing, almost everybody who has these multiple discs that are protruding and degenerating do show evidence of past Epstein-Barr virus reactivation, and they do have the antibody levels that would indicate they do have some autoimmunity. I think you've all heard me say a simple definition of autoimmunity is when some element of the body erroneously or mistakenly thinks normal tissue is foreign tissue and it attacks it. So we think autoimmunity is attacking these vertebra, these discs all the time. And so we'll stand on what we've seen so far. We continue to believe that the Epstein-Barr virus reactivation is a major problem, and we do recommend testing for people who have these spinal conditions. Now, is this an accepted thing throughout the medical profession? Heck no. There's a lot of doctors don't want to hear about it, don't accept it. Even people who are infectious disease specialists don't want to accept the Epstein-Barr virus reactivation the research that's out there. To me, the research is good. It's done by lots of people, not just me, and I think it's very firm. But that's my opinion, but I guarantee you there are opposite opinions. Okay? And now I do want to close by saying one thing. When you run into a doctor or a nurse practitioner, anybody in the medical field who says you just happen to have a disc because of wear and tear, and it doesn't make any difference what caused it, and don't worry about it, just take some Motrin and go to bed, or take 2 aspirins and call me in the morning. Don't buy that. We look at the disc degeneration as a serious problem. We think it's not taken serious enough. We think it's a signal to prevent things. We think it's a signal to be very careful with things like surgery and epidural injections. So we take this disc disease issue as one that's very serious to us, and I can tell you what our studies show. I mean, if it was me and I had 2 or 3 discs either in my neck or my lower spine, I certainly would want to have my Epstein-Barr testing, and I'd certainly get on a program to try to keep those discs as safe and as healthy as you can. Okay, so that's where we're at on this whole thing. With that, I'm going to try to call my good friend Dr. Ibsen if he is around. I saw he was here. Is he still on anywhere?
Hi there.
Mark, where are you? Mark, is anybody that's got good news? It's you, not just for yourself, but for the whole field. Give us the story.
I think we're talking about various causes of a pain in the ass. And so the Board of Medicine has been that to me. So last Friday, I had a hearing with the Board of Medicine to discuss a frivolous case that was ineptly presented to the board. But I found out that no matter how inaccurate or inept a case is, the board will go through the whole process. It doesn't matter if it's absurd or not. So we fought this. 50 people showed up on the video call. 8 or 9 people were able to share at the beginning about their interest in pain. And what we found out is that if people didn't mention my name, they were allowed to continue. And if people mentioned my name, then they were scolded and said, well, you can't talk about an outside issue. So we now know that anybody can come onto these meetings and talk about pain abstractly as long as they don't mention Dr. Ibsen. So, so that was great. You know, once again, we exceeded their capacity to tolerate 50 people on the call. Um, the, uh, the case was dismissed. Two key things in the case is that at the beginning of the case, the attorney for the board wanted to present the case. And so he started to present the case, and he presented the complaint, which is all lies. And I didn't really want that to be heard first. So I interrupted him and I said, excuse me, there's a long tradition in medicine that the doctor who's on the spot discussing a case is the one who presents the case. It's always been that way, grand rounds, etc. And so I proposed that I present the case. And the attorney said, no, you may not present the case. And so then I said, well, would it be okay if I did the legal summary then, if you're going to present the medical stuff? And I think that made a point to the board that they need to really separate the legal stuff from the medical stuff and the collegiality that we've been missing. So, you know, they dismissed the case. They have more cases that they can bring against me. It seems like the pattern is every time I get on a national show or something like that, they come up with another complaint against me. And so I'll just keep on keeping on. My next hurdle is August 25th, and that is a federal grand jury subpoena where I'm invited to appear before the grand jury. And that is um, a challenge because the risk of appearing before the grand jury, you can't appear with your lawyer. So my attorney doesn't want me to go because he's afraid I might. Oh, Danita, yeah, we'll get that link in there. So he's afraid that if I go there and he's not there to quell my urges, then I might incriminate myself. And my response to that is I've had lots of videos already, hundreds of them, that have been, you know, not particularly well filtered and spoken passionately. So I think I've already incriminated myself as much as I can in my videos. So I'm just going to go to there and beg for their mercy essentially and see if I can talk them out of indicting me. If they indict me, the Board of Medicine will suspend my license and 80 to 100 people will suffer terribly. So I'm interested in preventing the indictment, and that's why I'm going to go before the board. So wish me good luck. Any questions?
Yeah, Mark, I've got 2 or 3 questions here. Do you think the Montana Medical Board was very sensitive to all the outcry over your case? I mean, you've had more publicity, more people backing you than any doctor ever.
Yeah.
Do you think they heard this?
I think they did. I think they did. It didn't cure them of their anger with me because I keep winning cases. I have 13 cases I've won before the Board of Medicine, and they've won 0. So I would think that eventually they might learn something. You know, it's hard to get stuff into my head, you know, without a 2x4. So, you know, I think they're just kind of stubborn, and they have this attitude that I'm bad, and they just have to keep vigilant, and they'll find me doing something bad, and they can finally get rid of me. I think that's kind of the plan. But as long as I practice in a way that's above reproach, I think they can't win that. Yeah.
Well, that's great. And this almost looks like it's medical board abuse. I've heard a lot about that lately in other
Yeah.
states also. I mean,
Yes.
are these boards just kind of, they look like they're almost the vigilante committees deciding what they're going to do when they're on the march? I mean,
Well, there's a term called "with all due respect," and with these people, I don't think much respect is due. So I think you're right. You know, the people that serve on boards are at the end of their careers, and so are you and I. So we want to make a contribution, um, but I think that they're way behind the science, and they don't like being told that they're way behind the science. So other than them getting adhesive arachnoiditis, I don't see in a way to teach them anything more, because the The science is there and they're ignoring it.
Next is what can any of us do to help, if anything, on your case coming up?
We're not certain yet how public we're going to be about the um, uh, uh, grand jury. In other words, it's supposed to be semi-secret. It probably might backfire if we had a lot of people with placards out in front of the federal courthouse in Missoula. I don't know if we're going to go that way or not. I think that Susan has some plans to communicate with the assistant U.S. attorney. Ryan Weldon is his name. And, we'll be writing letters. The other thing that Flannery suggested is that I get a crew of expert witnesses together and have them write affidavits. So I've invited several expert witness types to write an affidavit, and essentially what I want to do is provide the board with those affidavits from yourself, Larry Peskin, Red Lawhern, Steve Arians, folks like that who can talk about different things. It seems to me that just bringing one expert witness in to deal with their one expert witness is a coin flip, and so I want a crowd of expert witnesses available. And I think that might prevent the indictment if we just get a lot of information in front of them. So, and if it doesn't, then they'll at least know that it's not going to be an easy trial if they put me on trial because I haven't done anything wrong.
Okay, I like that. Well, I'll certainly write a letter.
Thank you.
Yeah, I'll write a letter and whatever. I know other people will. I'm still not clear on what are they saying about why are they indicting you? What's their issue?
Well, they haven't given me any charges. So,
Well, that
so,
figure, yeah.
so I don't know what their issue is, but I'm going to consider it to be high dose patients. Almost all of my patients are ultra rapid metabolizers and taking large doses. And so that's the number one thing. Number two is state lines. In other words, I'm doing telemedicine, crossing state lines in order to do that. I use the Anazao company for some of my patients, and that compounding pharmacy is licensed in all 50 states, and it's very expensive, but it's very effective for the patients who can't get anything else. And you invented that, and thank you for doing that because half of these patients would be dead already if it wasn't for Anazao.
That's the new microformula hydromorphone, right?
Yeah.
Absolutely, yeah, absolutely essential.
Cutaneous.
Yeah.
No question about it.
So it's been a miraculous gift to the patients that I'm taking care of, and of course, my patients are anxious every month because they don't know if I'm going to be well or if I'm going to have a license or that sort of thing. So everybody's basically on tenterhooks, not knowing if they're going to have their prescription the next month. So it's an uncomfortable place to be. It's less uncomfortable than not having their medicine, but this uncertainty is not healthy for anybody, and it needs to get sorted out.
No, I have another thing I want to bring up to you. You may be aware that the federal government says that we can prescribe for legitimate pain patients, but they've never defined legitimate pain patients. Well, I want you to know that today I have written my own definition of a legitimate pain patient.
Oh, good.
And the medical boards, they haven't either. But I'm going to give you my simple definition, and I'll guarantee, and I know that all your patients meet this. Let me give you my definition of legitimate pain, and I'm going to be spreading this everywhere. My definition is a distressing symptom which is caused by a disease or injury that can be identified by diagnostic tests or physical examination. And I guarantee you all of your patients are more than legitimate.
Mm-hmm.
Okay? They've all got underlying diseases and injuries, and they've also got a distressing symptom. Okay? And
Yeah.
so I'm going to be putting that out there, and I'll be glad to write anybody and tell them, here's my definition of a legitimate pain. You got a different one? Put it in writing.
Yeah,
Okay.
yeah,
Let
I
it go.
love that. Thank you.
Yeah, I
Yeah,
mean,
I think that reminds me to talk about the fourth vital sign. You know, back in the 1999s, you know, we were talking about the fifth vital sign, and
yes,
you know, and having pain, and it, you know, it was a construct. It doesn't really make any sense. It isn't a vital sign because it can't be measured. But now what I notice is all of my patients in extreme agonizing pain have hypertension that is out of control. So
absolutely.
the the fourth vital sign is being screwed up by our ignoring the fifth vital sign. And we used to be uh, really obsessive about treating blood pressure in patients, but in pain patients, they don't care if it's 210 over 140. They really don't care. And I think that the hypocrisy of that is crazy.
It's crazy. Yeah. I wrote a paper one time called the Cardiac Adrenal Pain Syndrome, and nobody liked it, or at least the other side didn't like it. But what I found out is in all these hypertensive patients, if you also measured their cortisol, it was way down. Okay. In other words, these people, high blood pressure and in bed and have a pulse rate of 160. You know, I mean,
Yeah.
this is a no-brainer for anybody who cares or observant. So
Yeah.
let's lay that on them too.
Yeah.
Absolutely. Yeah. Mark, again, congratulations. You've been an inspiration for all of us as usual. Okay.
Thank you.
Jamie, I'm going to turn things back to you. Do you have one last thing you want to say?
Yes, sir, I do. I would like to share a beautiful invite, and it is a one-day adhesive arachnoiditis AA conference in beautiful Westminster, Colorado, free of charge as a public service by the Tennant Foundation. Donations are accepted. Lodging and meals are not included. This is the state of AA research and treatment, co-sponsored by Arachnoiditis Hope and ACM-CRN. This is on August 16th, 2025 from 9 a.m. to 5 p.m. and there will be an attendee dinner at 7 p.m. It says, join us for a very important conference set in the beautiful Front Range of the Rocky Mountains. Learn about the latest research findings and treatments for AA that have been discovered in the last 5 years. Join with others who are interested in AA. Patient success stories, breakout workshops, and plenty of take-home materials, open to the public and medical practitioners. See you there. And it also has some registration information that you want to go to arachconference.com. That's ARACH conference.com. You do need to register before August 1st, 2025. Lodging, meals, and transportation to and from the airport are not included. Make sure you have the new Real ID or a passport for air travel. It also includes your hotel information. And the contact email is contact@arachconference.com. And the seminar website is arachconference.com. And for the hotel reservation link, you can see that with the special rate as well. So we really appreciate this. The presenters are the world-renowned expert on AA, Dr. Forrest Tennant of Arachnoiditis Hope of the Tennant Foundation, and Evelyn Blackburn, Vice President and Patient Engagement with Arachnoiditis and Chronic Meningitis Collaborative Research Network, also known as ACM-CRN.
So thank you very much. We're going to have a nice conference and have a lot of people become AA educators. Thank you so much. Thank everybody for being here. Mark, again, congratulations. And we'll see
Thank you, Dr.
everybody.
Tennant.
We'll see you next week. Bye-bye.
All right. God bless us, everyone.
Good.
Everyone. Thank you all. Good night. Thank you all.
Good night.
Good night.
Congratulations, Dr. Ibsen.
Thank you.
God bless you, Jamie. I can't believe you're here tonight. I love you.
I love you too. God bless you too. God bless you all. Dr. Ibsen is sick as well, and he showed up, gave me some
Yes.
strength. Shoo. Thank you all.
Show up and show out.
That's right. We got to fight. If we don't, who's going to?
That's right.
Right.
Love y'all.
Love you all. Good night.
Love y'all. Good night.
Good
night, everybody.
Thank you so much. Congratulations, Alan.
Thanks.
See you.